Hey Musa, how are you doing?
I'm all right. How are you, Jonathan? It's been a long time.
I'm okay. A lot going on, but I'm sort of surviving it. What have you been up to?
Okay.
You've been away.
Yeah. I was in Uganda for a couple of weeks actually. I was there with the charity, the Humanity First,
Uh huh.
um, uh, looking at kind of psychiatric mental health care in Uganda, and it's the first time I've been. I've just found it, yeah, really spectacular, amazing time I had there, and I've been really surprised, really surprised.
Well, so I mean, I have no idea what this is. I have no idea, but I now I'll find out what surprised you later. What was it called again?
The charity is called
Yeah,
Humanity First. Yeah.
and what is
Yeah.
Humanity First?
It's I think it's charity. I think it was started 94, 95. Faith-based charity. So kind of Muslim perspective, but it's a charity to, as it says on the tin, put humanity first. So it's open to all, in terms of humanitarian relief, disaster relief, healthcare, clean water for all, these kind of things. It has a medical arm.
Hmm.
It's spread in multiple countries. So there's basically, this is not exclusively how it works, but basically, mostly Western countries are kind of donor countries, developing countries are recipient countries. There's work that is done in Germany, UK, America as well, particularly homeless, uh, floods, these kind of things. But most of the work, um, or for, at least in the arm that I sit in, is Western doctors going over, and trying to help kind of either capacity build or some kind of disaster relief in various countries. In this case, it was Uganda.
And what's capacity build?
Oh, so look, the thing is, if I go to say Uganda or Bangladesh or Pakistan, anywhere else, really, and I do a clinic for a couple of weeks, it's only going to be of limited benefit, isn't it? You know, it's how is that really going to help the people in the region? So you have to think a bit more broadly about what you're going to do and kind of upskill, uh, sort of health systems, deliver training, ways of thinking, those kind of things. That's what I mean by capacity
And
building.
where had you been before?
So,
Where else?
so I
Is this the first time
personally,
you've done it?
yeah, well, with Humanity First, yes. I mean, I've been to Pakistan. I go every year for a couple of weeks,
Hmm.
um, to run a clinic. I've also, when I was a medical student, I went to Gambia.
Hmm.
Um, but I don't know if I was any help there back then. I went to Senegal as well, but I wasn't doing anything professional in Senegal. Yeah, so yeah, essentially, this is my first time in any
I wasn't
serious
doing anything
capacity.
professional. You went on holiday after the Gambian thing. Is that what you're trying to sort of?
Well, yeah. No, I went for a month to Gambia, and 1 week we went to Senegal. Yeah,
Like, okay, so look,
yeah,
let's get back to it. So you're a psychiatrist and you go
yeah.
out. What does someone from the UK do? What's the plan? What do you go out and do in Uganda?
Okay.
This just sounds a bit.
I
I mean,
mean, yeah.
I
Sure,
just
sure.
don't know.
I mean, when I went, I wasn't quite sure of the plan. You know what I
Hmm.
mean? I thought I heard there was this camp going. I thought I better just tag along and find out what's going on. And I'm always, whenever I go, even when I go to Pakistan, which is a country I know very, very well, I'm always a little bit anxious about what it is that I'm actually going to do or deliver. So the first, I think, day or so, couple of days, I just went to to a medical camp, right, with a whole load of other GPs from the UK. There weren't very many cases, from a mental health point of view, because the triaging system doesn't essentially work. I saw a couple of cases which were really interesting and gave me a flavor about, what's going on. There was, a lady I saw who was suffering with epilepsy, who was stigmatized by the fact that she was, being attacked by demons. Um, at which point, I quickly disabused her of that notion in a kind of, I hope, culturally appropriate way to say, look, this is a medical condition. It needs medical treatment. Please don't go down that route. I think she was very happy with that. Actually, I saw another lady with what are called non-epileptic attack disorders, right? So they're seizure-like episodes, or they are seizures, but they're not from an electrical discharge in the brain. They're from psychological, psychogenic causes. In this case, she had other medical conditions, which we need to look into, right? But in itself, going out in the sticks and doing a mental health camp is not that useful. So then we decided to go to Helper Hospital. So I went to a place called Mbale, to the government hospital. And the thing that kind of shocked and surprised me, and really made me think about how I practice my profession, is I came across a ward, which is a very typical ward, of 34 patients, around 700 outpatients attending that facility, which was not staffed by a single psychiatrist, but staffed by what they have in Uganda called psychiatric clinical officers. I think there were 4 or 5 what we call PCOs, who are people who basically do a diploma and then can assess mental state examination, can prescribe, can diagnose, can make really good treatment plans, actually. And they were doing an outstanding job. And I just kind of suddenly, the world slipped from, under my feet. And I realized that, well, maybe these were very, very sick patients they were seeing. And I was like, well, maybe my job isn't that necessary after all. It can be done in, with minimal resources, in highly constrained circumstances. And to be honest, it was shocking to me. And I have to take my hat off to, the people who devised the program and the way that it's working.
So what was it they were doing that was so good? I mean, give me a picture of it. One, why were the circumstances so restrained? What was limited resources? What would be the equivalent? So I can sort of see Uganda, and I can sort of see a central London hospital. And then what were they doing that was working?
So just to give you some overall figures, these are from memory, so I might have got them wrong. The per capita GDP in Uganda is, I think, $1,340 per person, and the healthcare.
Which means.
Well, I mean, in the UK, US, we would expect it to be what, $40,000, $30,000. I mean, they are severely constrained. Severely. The healthcare spend per person, again, I might have got this wrong, but I won't have it massively wrong, is about $56 or $60 per person, right? For the year. Per year.
And here, what would it be roughly?
I don't know. Probably, what, a couple of grand, I would imagine, at least. Okay. At least 1,000, but substantially higher. So it's really constrained. In a country of around 50 million people, I think it's 46 million on the census, but there's probably 50 million people. There's people who haven't been counted in Uganda. There are 80 psychiatrists for the whole country. Here we have 60 million people, 60 to 70 million people. We probably have, maybe north of 10,000 psychiatrists. I don't even know how you begin to count the number of psychiatrists we have, the number of subspecialties that we have. We have consultants, we have junior doctors, we have trainees, so we've got lots of doctors working mental health. We still complain that
and you still can't get to see anyone if you need it.
Yeah, exactly. Absolutely. So there's 80 psychiatrists in the whole country. Mm-hmm. Most of them, as happens in developing countries, cluster around main cities, the capital, Kampala, and therefore rural areas get underserved, right? So these are the kind of constraints they're working in. And the conditions that they're seeing are exactly the same conditions that I would see here. So people have bipolar disorder, they have relapse of bipolar disorder, they have various psychotic conditions, they have schizophrenia, schizoaffective disorder, puerperal psychosis, all of this stuff I saw, right? So I don't know how much I've talked to you about this before. There's two broad categories of mental illness. You can talk about serious mental illness, SMI. You can also talk about common mental disorders, CMD. CMD is kind of probably up to one in five of us. Many of us suffer from depression, anxiety, these other things. Serious mental illness is probably 1 to 2% of the population. It's always been a marginalized, stigmatized group. It's always been very difficult to treat. So in this particular unit that I went, which is one of 13 or 14 regional hospitals, right? They had around 600-700 people on their books, all of whom had this, what I would say, SMI, serious mental illness. They were, I interviewed many of them myself. I saw the clinical care taking place, and I could just see this kind of remarkable interaction that they have nothing literally, and they've still designed this system to be able to care for these patients. I was just stunned.
So what did you learn? Did you take away a better way of doing things?
Yeah.
Or a different approach, or a different understanding of mental illness?
I think the biggest thing that I learned is that in difficult circumstances, people will find a way. And I think that's the most important thing that I learned. So what happened, basically, this PCO program, which I'm very, very impressed by, is that 40 years ago, a professor of psychiatry kind of realized that this was a problem. So he began to develop this program of PCOs. And this links really directly to the current conversation that we're having in Britain about, you might know about this, about physician associates, right? Associate physicians, de-skilling doctors. All of this is happening in Britain right now.
What is? Just clarify for me. What is a associate physician?
So an associate physician is not a doctor who is very often likely now to see you in your GP surgery, in hospital, maybe in your mental health clinic, although there's been a few less of those, who will be, your first point of contact, will take an interview, will take your history, may examine you, will prescribe treatment and various other interventions. Doctors, the BMA union, and others are up in arms about this, as I have been as well, saying, well, what you're doing is de-skilling doctors, you're getting medicine on the cheap, and such like.
So I'm drifting from the point a bit. Maybe I lost concentration. But what's this got to do with the piece?
Well, that's what they're doing. That's what they're doing in Uganda. They've got these psychiatric clinical officers, which are basically associate physicians. Except the thing is, associate physicians operate nominally under the supervision of doctors, whereas these PCS don't. They operate independently because they have to operate independently. And the fact is that what I saw is that they do a decent job, of providing healthcare. The other thing about Uganda, which is exceptional, I find this absolutely exceptional, is that healthcare in government facilities is delivered free of charge. That is amazing, from my perspective. A country which basically has nothing is delivering healthcare free of charge. So it says that now there's problems with it. There's problems with getting certain medications. There's problems with the amount of time people wait. It wasn't unusual for me to see people waiting 4 or 5 hours. But there are different ways of solving healthcare crises, which in this hyper-resourced world we can't even think about.
Yeah, I mean, you realise I'm hearing all this with a.
Yeah, go on.
Well, here's the thing. Whenever I heard you were going out there, I thought, that sounds great. Oh, Musa's doing some really good work, and this is wonderful, and I wish I could do something like that. And yet at the same time, I always have this thing about these sort of exchanges, these sort of the West brings its best, and everyone's very thankful. And as it brings its best, it obviously brings its best knowledge, and its best knowledge comes with certain models of understanding. So it brings ideas of psychiatry, and it brings ideas of epilepsy, and it brings all these things with it. And in a sense, it also does another thing, which is it gets a snapshot. So if I turn up somewhere for 2 weeks, I'm very much gatekeeped. There's gatekeepers explaining everything to me, giving me their, what needs to be said or what they personally think. And what normally happens, this very common experience, is we come away thinking we understand something. But of course, if we sat there for a year, we'd see it incredibly differently. And if we were in it, we'd just be part of the debate. So there's that question. Then we have the question of low resources, but people find a way. Well, welcome to the trouble of the world. You can just keep stripping back because people will always find a way. But of course, if you gave them more resources, they might find a better way as well. And of course, if you then create a massive institutionalized system, it'll tie itself in knots as well. So, I mean, you've got all these tensions going on, and the tensions of how do people there see it, and how do patients there see it, and how do the patients you can't get to see it, and what is this faith charity doing? Is it doing it for humanitarians first, or is it doing it kind of for itself? I mean, and yet part of me thinks this is wonderful as well, and I think it's all these things at once. And I know you're a very reflective person. I mean, how do you see all those things? Quite a lot there.
Look, the thing is, Johnny, I don't disagree with anything you've said, right? Perhaps you've disabused me of some of my notions, right? But actually, the narrative is really messy. If I told you this, I've just told you one aspect of what I've seen, right? Which is the most striking thing for me, which is hang about, this can be done. Yeah. There's another aspect which which is completely at variance with what I've just told you. So behind the mental health unit, which I've just talked to you about, there was a drug and alcohol unit, actually a drug unit, opiate substitution therapy. That opiate substitution therapy, I've actually done a different video for this in order to raise the profile of this unit, right? Because it's something I'm very worried about. It is a modern, essentially Western facility, which does methadone treatment as buprenorphine treatment for people who are addicted to opiates. So basically heroin. People also inject tramadol, pethidine, other things, which can be obtained through a pharmacy over the counter. There's different ways into opiate abuse in Uganda, but I won't go into all of that, right? But there are some similarities. These vulnerable populations, including sex workers, sexual minorities, other minority status as well, certain labor classes, these kind of things. That was funded by USAID. USAID was essentially had its funding cut off in February 2025 of this year, plunging that unit into crisis. It was looking after around 100 people on opiate substitute therapy. There were 11 workers, full-time workers in the staff. It's a fantastic unit. When the video comes out, I would advise people to look at it. Yeah. For 10, 15 days, they didn't know what to do. People were in crisis. Some people relapsed. Some people had to relocate 4 or 5 hours away to Kampala, which is the capital city, where there's still a similar unit. There are risks of bloodborne viruses as well, of course, if people inject, including HIV. It's massively worrying. And so they reopened it on the basis of the methadone stock that they had left, on a voluntary basis, right? So there's a couple of people who are working there completely voluntarily. And they're very, very worried about the fact that they're not going to be able to continue the service. And essentially, when I turned up and I told them I'm from this charity, I'm here to help, I suppose the expectation of the question is, well, can you help with this? Of course, we're a small, very small medical charity. In the scheme of things, we cannot at all, afford to bankroll this. But I did say that I would try and get a video out to make, to see if any international donors can look at this. This is happening all over Africa, incidentally. It's happening in Uganda, certainly. USA cuts have devastated healthcare, right? So that example doesn't square nicely with, what I was saying beforehand, which is people find a way, right? There is need. That need is unmet. What can you say? There have been allegations from the Americans, the current administration, that USAID funds were used in a corrupt manner, which I'm sure they were. I'm not talking about this project, but in general, money comes with, well, healthcare comes with money. It's the opportunity for corruption, especially in impoverished societies. Was this a blessing or a gift from America to Uganda and the Africans? Is it wrong of us to be angry or upset when the funding, dries up or is not there? These are very difficult questions. I don't have an answer to them. What I know is that I was profoundly troubled by what I saw.
And what do you think the impacts are on human life there? What do you think, by this happening, what do you think the actual impact, if I was using that clinic?
Oh,
Do you think
the impact, it can be immediate. The impact could be that you can't get the opiates that you need. You can turn to crime or sex work or other things in order to fund the opiates that you need. That can lead to high risky behaviors, including, HIV, hepatitis B, hepatitis C, increased crime, lack of stability in the local population. There's massive impact.
Well, you see, and it comes back to the other point.
Yeah.
People will always find a way. People will adapt. They're resourceful.
Sure.
So it just how they adapt and where they're resourceful is what's available. So if there's nothing, if all that's available is back onto the street and living those lifestyles, then that's the form of adaptation. But the other thing I think maybe, I've worked drugs and alcohol, so I say it a bit differently. But how would you? Because I guess some people look and they think, well, hang on, why are people supplying people with opiates who are on opiates? Why are they supplying them with opiates? What's the thinking behind that?
Well, I understand that debate, and we could do a whole other program on this. But
just tell me what the thinking is, because
well, the thinking is not just the thinking. The evidence is that opiate substitution therapy with a long-term opiate can stabilize people's lives and lifestyles, so they could go on to be productive. Because an addiction to opiates or heroin, these kind of things, can turn your life upside down. In fact, some of the patients I saw in that clinic who were using it on a voluntary basis, some of them were nurses. Some of them were doing professional jobs. They were able to stabilize their lives. And actually, there were some really good principles of prescribing. I won't go into everything, but, they were actually also slowly cutting down methadone and getting people off the stuff as well, So it was a proper treatment intervention program. There's a huge debate, about whether you should stabilize and keep people on low doses, whether you should get them off it. But they were doing a really good job, and they were turning people's lives around. And that's all I could see from the very short visit that I saw, So I don't have all of the data of everything, but I could see that there is a real problem here.
And would you do it again?
What, would I go to Uganda again?
Yeah.
Yeah, I'll go next year.
Or would you go elsewhere? And why did
Yeah.
you do it through a faith-based charity? You could have done. I'm sure there's hundreds of development charities out there doing it. Why are you doing it through a faith-based charity?
Well, I think the faith-based charity is Humanity First is accessible to me. I know the network. I'm on the WhatsApp groups. They said they were going. That's one thing. I'm also on I'm the voluntary international psychiatry and volunteering special interest group. It's called VIPSIG and the Royal College of Psychiatrists. And I know it's actually not that straightforward to, you think that there's hundreds of development charities. It's not that straightforward to volunteer your time and effort. There's lots of complicated things about, clinical liability, logistics, all these kind of things. You also need an in. That's the biggest thing, Jonathan. You need an in with an organization that can help get you into places. You can't just pitch up and volunteer. It doesn't tend to go well, So you need those institutional relationships. And we've talked about this before. Charity inherent part of Islam. So yeah, that's one of the reasons why I do it.
Do you think you'd do it if you didn't have a faith? Do you think that's just who you are?
I don't know. Well, I probably wouldn't do as much as I do, but there's lots of people without a faith who do these things. Yeah. So it's one of the driving forces for me. It's not the driving force for everybody, right? Yeah. It kind of helps to coalesce an intent, and for us, there were 8 doctors who went on this trip for us to go together, with a kind of shared understanding of what we want to do. And the question that you're getting at is about motivation, right? Is that right, John?
It's a deeper motivation. I'm wondering whether the faith is a vehicle or whether the faith is the fuel.
I can't answer that, John. It's very difficult to talk about oneself, isn't it? What I can say is that there are complex motivations for why people go. Or why there's complex motivations for why people engage in charity. That can involve a sense of altruism. It can involve a sense of shared humanity. There can be religious didactic commandments like there are in my faith. It can be to assuage some level of guilt. It can be for fame or for prestige. The reasons for why I do it escape me. They're beyond me. I can't think of myself in
Are
that.
you drawn, or are you drawn to do it? Do you feel something will happen to you if you don't? Do you think something will happen to you if you do? I mean, what's?
I think it's an obligation on me. One thing that I know that other people may not share is that my prayers tend to get answered when I do things like this. People may say that's a cognitive bias. I don't know. It's something that I certainly see. Yeah, but I don't see it as an option. It causes problems with my family sometimes, right? They look at me slightly quizzically, and they think I'm going off on holiday, which maybe I am. Maybe I'm going because Uganda. We haven't talked about a beautiful, beautiful country. So maybe I'm enjoying traveling the world as well.
I mean, there's two, there's 2 things I do want to ask, which
Go on.
I'm putting off asking. I mean, I want to come back to the demons, and of course we've got Uganda, which you touched upon. I mean, Uganda's human rights record. If we look at things as human rights around LGBT, I can never do the forget me with letters in the
LGBTQ.
Yeah, good on you. Yeah, I mean they've got real issues there. I mean, really criminalizing and punishing and violently punishing. I mean, did you see any of that in the background, or are you kind of further back from it?
The president of Uganda is called Museveni. He's been there for 40 years, yeah, I think, or thereabouts. There are elections happening right now, there's posters all over the place, there's rallies all over the place. I don't think anybody really thinks that Museveni is not going to win the election. He's going to win the elections. Um, uh, I didn't directly come across, LGBTQ violations. What I
Sorry,
found I'm not
so
seeing.
wait, just to clarify,
Yeah,
what's I can't do the letters in the right order. What's the letters violation? LG.
I understand that there are laws being passed against sexual expression for these minorities, right? I don't know the details of them, right? Yeah. I know that from the conversations that I've had, there are some politicians have said, I've seen this, that these minorities don't exist in our country. Clearly they exist. Do you know what I mean? I can say that much. I can't say that much more, Yeah. I can say that services to help these groups, especially help services, are sorely needed. Yeah. Okay. I apart from this, and I'm not. I do wonder if Ugandans feel that Westerners come and bring their concept of Western justice on and impose it on them. Yeah. I had some very interesting conversations about Idi Amin. Many Ugandans are staunch supporters of Idi Amin, right? And obviously Idi Amin kicked out all of the Indians and the Asians, and I would assume myself to be, be one of the Asians, right? Um, and I think you just have to listen. Do you know what I mean? I mean, it's not my job to go and tell people what to do, what to think, right? There are clearly I have certain views, but we also need to listen to what people are actually saying. Does that make sense?
Well, because it's complicated, isn't it? If we really started to pick it apart, because there you are going with these models of medicine. There's
Yeah,
someone who
yeah.
hasn't really got demons in their head; they just have a electrical disturbance causing something we call epilepsy. And all the Ugandan stories of demons are not true, but it's not for people to come from the West and tell the Ugandans how to live and how to see sexuality. It's I'm not saying there's an answer, a simple answer.
Yeah.
It's not, because we're into this thing. And who are Ugandans? Ugandans, if you said, "Oh, this is what the Brits think," I'd probably find you some
Sure,
people
sure.
incredibly quickly who didn't think the same thing at all.
It's a
And for
fascinating.
those who experience something this way, so you don't tend to legislate punitively against majorities. That doesn't tend to happen, except in a revolution, perhaps. But you sort of, how can I put it? You do against minorities, because, and at that point, the lived experience is everything. And you can say, well, who am I to tell them how to be with others? But surely within your faith, there's something about treating, and with an organization called Humanity First.
Mhm.
Isn't humanity coming first, or is humanity we don't talk about that because it's a bit awkward? I don't know. Maybe it is.
Look, okay. So my question would be that okay, I understand the LGBTQ debate, and I understand why it's being raised, and it's an important aspect of things. There are specialized kind of groups which are raising this. Yeah, I don't have enough information, to be able to castigate the Ugandans, one way or the other, although the stuff obviously I've heard mostly from Western media has not been good, right? Alongside that, and this is where things become really tricky, right? Uganda is probably under dictatorship rule, right? It's unlikely that it's a genuine democracy lasting for the last 40 years. Yeah. That's not how many of the Ugandans that I spoke to saw it. They said that, yes, we have a central boss who they call Big Man, right? But there's freedom here. There's freedom of religion. There's freedom of faith. There's a lack of terrorism, ethnic strife, as have been seen in other countries. In Rwanda, of course, which is a neighboring country, there was a genocide. Again, it's very clear that would never happen with us because we have a cohesive idea or understanding of what it means to be Ugandan. And there's things that the government are doing which I would say are great. I think it's really good to be providing free healthcare. So we have to see things in the round, isn't it? And in the round, there can be awful things. There can be awful things that happen.
This is the problem.
And they can, yeah.
This is the problem. Maybe if you went to a different town, they would have different views. Or maybe we went to a town where they felt able to express their views and trust you they express their views. Because if you're saying it probably is a dictatorship, then it's probably people who aren't so happy with it, but know best not to say, or they're in certain regions where they can say. These would be the things. Not that we should laud the wonders of Western democracy as some sort of holy experience, free from all trouble and corruption, and nor should we actually castigate. I mean, that's an interesting word you said. I don't know, we should castigate them, but surely, especially on this what we're doing, surely we should be having conversation with them and finding out where that conversation can go. Is it possible? Is it possible? Is it possible Jonathan, to dig in and understand them?
Sure.
Better, whoever they are.
Is that the question is? Is that my central role, or is that somebody else's role? It's a valid. It's a tricky one. It's something that I struggle with. Do I need to? If there's something you don't like about a country or a people, or there's something you don't agree with, at what point do you just listen or let people express their views, and at what point do you stand up and start advocating? And I don't know the answer to this, Jonathan. I do know. Yeah.
Go on. I mean, it's just this. I mean, you can all. The clues are there that it's complicated because, of course, as you're aware, Uganda borders Rwanda, and you may not know, but as the RPF come in, they've been living in Uganda in the refugee camps for a very long time. It is kind of part of that war. And there's a war going on. It's still going on in many ways. And they also have a leader who has been in there since 1994 or thereabouts. So what are we getting on for 30 years? And whose political opponents keep falling off balconies and things. So that's part of it. And people are aware of these things. They might not be able to express them, and you would have no idea because you'd have to have a huge understanding of some of these things to understand what's going on. So in a sense, we're the last people who should comment. But in another sense, the beauty of there's the meeting, isn't there? There's the meeting between the outsider and the insider. They appear almost as two different figures, but they're not really. And there's the idea that the outsider has come somewhere with a role, but obviously they're playing many roles and they're affecting the environment they're in and they're being affected by it. And in that meeting, what should really happen in that meeting? Should we just turn our head to some things that are not involved in others? Should we start saying, no, I'll tell you how you should be living, or this is wrong, or this is right, because we have very little understanding of things where they are. What are we meant to do? How are we meant to travel? That's what I mean. This is what I find fascinating.
Isn't the first thing that we should do is listen? Isn't that the first? So I'll give you an example.
Mhm.
So I turned up to this camp, and I asked, obviously, to speak to the dispenser or the pharmacist. And I said, "What mental health medications do you have?" Right. The first medication I was told was something called phenytoin, and then barbiturates. I don't know if you know. You might not know. These are medications which are ancient history, 50, 60 years old. Right. You get worried when somebody starts telling you that the medications that we have basically for mental health are these strong anticonvulsant drugs. Carbamazepine, all of these kind of things. Right. Um, they're not. These are not medications I prescribe in the UK. I avoid them. In fact, I think I've hardly ever prescribed some of these medications in the UK. I avoid them as much as I can. I would say that I use far more sophisticated medications. I certainly don't try not to use something called polypharmacy, which is give many drugs at the same time. Um, I try and make sure that all of my patients are counseled in full about all of the likely side effects of medications. They have full informed consent, all of these kind of things, right? Um, I am also particularly aware, being in the UK setting, of the problems of prescribing some of these medications to young women who may be of childbearing age, and effects of something called teratogenicity, so effects that it can have to unborn baby, and the fact that people can be pregnant without knowing that they're pregnant. In fact, that's the highest risk, in terms of medication, right? Or the time of giving medications.
Mhm.
I know all of these things, right?
Mhm.
When I see that these medications are being prescribed, do I go in there charging and say, well, why are you prescribing this? You must stop this. You must stop that. In fact, if I stop these medications, there's a risk of relapse. There's a risk of other problems downstream, which I can't see, you know? And therefore, it behooves me in the first instance to understand what's going on and to listen, perhaps to counsel, which I did actually try and do. That look, we need to think about the effects of these medications on the unborn child, especially if we're giving them to young women. We need to perhaps tell the person that we're giving the medication to about risks of teratogenicity, and perhaps we need to counsel that while you're on this medication, you might want to think about family planning, right? And that message was received very well. If I'd gone in, I know many of my colleagues would have, what are you doing? Why are you doing this? Um, it wouldn't have gone down very well. So, firstly, perhaps you need to listen a little bit in order to build that relationship and to understand where people are coming from.
Lucy, you sound like you read my book. So look, I want to ask you another question.
Yeah, go
Um,
on.
I want to come back to those demons because they're still
Oh, yeah.
still playing with me.
Okay.
You said this woman's demons weren't really demons, but aren't there demons in the Quran? Or have I confused it with another book? Are there any mentions of demons?
Okay.
And are they real or are
Uh,
they just electroconvulsive?
okay. So, what are called demons, what you're talking about, are called jinn in the Quran, right? Yeah. There's various conceptions and understanding of what the jinn mean in the Quran. Okay, um, some people take the jinn to mean a species of being that we don't interact with in general, but are there, right? Some take the jinn in the Quran to mean, a specific type of person, who may be of a fiery temperament, may have aspects of arrogance, these kinds of things. Others take the meaning of jinn in the Quran to be those beings which we don't have much knowledge about, but certainly do exist, right? So some people have, in some of the um, tafsirs, some people have also said that jinn can also indicate, bacteria, other kind of things. It's an indication that the creation of God is not limited to mankind alone. Okay? Yeah. The conception, popular conception, has been of jinn being demons. Okay? As a psychiatrist, I sometimes come across this. I come across it in Pakistan. I come across it in Uganda as well. In fact, the lady that I was speaking to happened to be a Muslim, although it's not only some Muslims who believe in, demon possession and these kind of
Definitely
things.
not
Yeah,
only
yeah,
Muslims. Yeah.
She was. I don't always dismiss out of hand Jinn possession states. I don't personally completely believe in them, right? I am very skeptical when people tell me about Jinn possession states, right? But sometimes it doesn't behoove me to talk about. And again, similarly, I've treated evangelical Christians who believe that they've been possessed by the Holy Spirit and these kind of things. There's a really good psychiatrist called Simon Dean that you can look into, who talks about how to treat this. You can have two conceptions of reality going on at the same time. You can give credence to that, or you can allow people to believe that, but at the same time say that, look, there are mental health aspects here and we need to treat those things. Does that make sense? Right? So yeah, go on.
So you're saying you can actually contain more than one point of view, and
Absolutely.
that's not a big issue.
In this particular case, this lady was having epilepsy. She was biting her tongue and she was urinating while she was having the seizures or fits at night. She gave me a very good history of epilepsy, and she was stigmatized because her family members were saying that she was possessed. At which point, I think the appropriate answer is to say, you're not possessed. This is a medical condition. This is epilepsy. This is the medication for it. Does that make sense? So, I mean, there's a bit of subtle thinking about it. If she had said that, no, this is my faith and my deep held belief that I am possessed, and you, the psychiatrist, are the witch doctor, then I would have tackled it in a different way. Does that make sense?
Just briefly, how would you have tackled it?
Well, I would have said, well, I understand that that's your point of view, and that might be true. I can't completely rule it out myself, But what happens if I gave you a medication and these fits stop? Would you want that? So why don't we try that? So yeah. What I find interesting, sometimes slightly worrying, is that psychiatric people in my profession use ideas of jinn possession, the evil eye, other things, right, to suggest that Islam is some kind of backward religion because some Muslims believe in these kind of things. And I mean, we've had these discussions before. There's a heterogeneity of belief, of understanding. You cannot just transpose somebody's understanding of one thing and just apply it to 1.8 or 2 billion odd people, right? Does that make sense?
I mean, it does to me. I think there's a heterogeneity of existence and
Yeah.
of forms of being, and what's that Shakespeare quote? There's more to heaven and earth than in your philosophies. I mean, I find it backwards where people aren't able to contain other points of view, aren't able to contain other experiences, or in themselves don't go seeking other experiences. I find that somewhat, but it's that exploration. I'm not sure if it's backward, but it's a bit of a funny term, isn't it? But
I think
I like to be.
I think there are times when I need to intervene, right? And then there are times when I need to reserve myself, right? If I find that a certain health belief is leading. So, for example, if somebody told me that they're using homeopathy, I'd be like, fine, use homeopathy. If they tell me that they have a terminal cancer and they're not having their chemotherapy or radiation therapy that they've been recommended, or the surgery, and they're using hyperbaric oxygen therapy and homeopathy, then I'm going to challenge it, and say, well, perhaps you need to go with kind of what the medical advice is, right? So I think we need to be careful in balancing things, and we need to think really carefully about when we're going to intervene and challenge those health beliefs. That's my personal view.
So I tell you what, we'll talk again, but we'll talk about the total distrust let's talk about distrust, because medicine's part of it, and you see people capitalizing on that. But what's distrust? What should we trust? What shouldn't we trust? And how do How do we get to deal with that?
Yeah.
Look, Musa, it's been very nice. It's been very nice. I'm glad you kind of did what you did. It is very odd tension in me. I'd love to do it, and I'd love to question it too. So I don't think there's much development need for people who just ask questions all the time. Look, I think we leave it there if you want. I mean, I know you wanted to talk about the pandemic inquiry, but I think I think you're the only person in the UK pretty much interested.
I think that's the
sad, maybe.
Yeah, I think it leads into this question of trust and distrust, isn't it? We'll leave that for another day.
Yeah.
All right. Fantastic.
All
Thank
right,
you very much,
Musa,
Jonathan.
thank you very much. I'm glad you're
back.
back.
All right, mate. Cheers. Bye.
Yeah.